All right, I'm here with Chuck. My name is Travis Robbins, and we're doing a training on the differences between therapeutic exercise, therapeutic activity, neuromuscular exercise, neuromuscular reeducation, and manual therapy. And I hope Chuck he's talked about this in our live events, but the reasoning behind why codes are paid what they are, and some definition and some understanding around what the codes are and how we're going to code for things. I think I've done it successfully so far, but we don't say the word bill. For some reason, therapists really struggle with that. So it's just coding. It's just putting things in proper places based on definitions that have been established for a very long period of time. All right, Chuck, take it away.
Great, perfect. Hi, everybody. So one of the first things that you need to recognize to sort of set this conversation is how payers perceive the value in what we do and how they've categorized that and thrown us into codes. A really, really long time ago when I was a therapist, almost everyone was just a flat rate. You just came for a visit. We're going to pay you this for a visit. You do whatever you need to do with that patient, and we're good. And boy, life would be easier if it was that way, and they actually paid us what we were worth. But that's another topic.
Caveat, small chunk of that. That would be great if they paid us what we're worth. Okay, I digress. Continue.
So, so what most payers have done, Medicare is kind of the lead on this, and most of the payers will follow that if it's to their advantage, have perceived those four codes as some more valuable than others. So 97,530 therapeutic activity, they value the most, and because they value that the most, that's what they pay us the most for. 97,112 neuromuscular re-ed is below that. Followed by that is 97,110 TheraX. And bringing up the rear is probably what takes the most skill, education, knowledge, and judgment of all the things we do. Manual therapy 97,140, they pay us the least for. Now, over the course of all of the different practices and physical therapists we've worked with over the years, what we find is that there is way more coding of 97,110 and 97,140 than what could actually be carried out. That's kind of the purpose of this talk, as to how to sort of make that shift. We're trying to move a lot of the 97,140s and 97,110s up to that level of therapeutic activity in neuromuscular by simply renaming it. The reason this is important is small changes in a single visit by the end of the year create huge gains in revenue. So let's talk about selecting CPT codes. And the way you select a code is by the intent of that intervention, not the actual intervention. So on here, I've got some definitions of therapeutic activity, neuromuscular rehab, TheraX, and manual therapy. I'm not going to read through those, but basically what we're going to do is let me scoot down here. And so how do you describe things? So 97,530 therapeutic activity. The hint is that, a lot of folks will call that an ING code, lifting, carrying, twisting, turning, rolling, functional things that we do throughout the course of our lives. So how do we describe something to be more functional? My favorite example is single leg stance. So if you stand on one leg, if we look at, let's go back up. If we look at therapeutic exercise, helps to develop strength, endurance, range of motion, and flexibility. Travis, if I make you stand on your foot a lot, will you get a little stronger, have a little more endurance in that glute med?
Yes.
Absolutely.
Yeah, along with other joints. Mm-hmm.
So I guess 97,110 is the code for standing on one leg.
Okay, I got it, Chuck. We're just going to do it that way from moving forward, right?
What's that?
I got it. That's all. One single advance is
There's
9
nothing else to talk about.
Okay.
What if I make you stand on that one leg? Will your balance, your proprioception, some coordination, will that improve so that you don't fall flat on your face if we do it in the appropriate manner?
I think that's right as well, Chuck.
Yeah. So now we're talking 97,112.
Okay.
I don't want to dive too deep into your personal life, Travis, but do you have to stand on one foot to put your pants on in the morning?
I do.
There we go. Now it's magically 97,530. So it's the intent of what it is you want them to be able to do. So this talk isn't for the entire meant for the entire compliance of writing a note, but you've got to have goals. Of those goals, the interventions you're going to do are going to meet those goals. So you need to tie those together. You need to have a functional goal of being able to stand on one foot for whatever particular activities or purposes, so that you can tie that into the interventions that you're doing. Some other examples: the classic overhead pulleys. I put passive range of motion in quotes. I don't know that all those muscles are completely quiet as we're doing this. So 97-110, passive range of motion for shoulder elevation, right, Travis?
That works. Yes, I believe it does.
Uh, what if we're doing that to help them reach overhead,
So the intent is to improve their ability to reach overhead.
improve their ability to reach overhead? And some folks will say, well, that's passive range of motion. I would tell you that that is a gradient process of getting them to be able to reach over their head then actively, and then with some type of resistance, a weight in the hand or something like that. But in that gradient, that's still a functional activity. So
Mhm.
it's what your intent is, and then how you describe it. Overhead pulleys for reaching overhead. There you go. Now you voila, you magically made it 97,530. Now, if we want to talk about 97-112 neuromuscular re-ed, actually, I'm going to kind of flip it a little bit, and I'm going to throw some things out there to see that maybe we don't use that for 97-112, but it could be. So my favorite single leg stance, I got to throw that one in there. So we've already talked about that. But how about Mulligan mobilization with movement? I know a lot of folks will bill that as 97-140 manual therapy. It could fit into manual therapy, but it's also fitting in to neuromuscular re-education. You're you're guiding that patient into a more efficient movement pattern.
Okay. And what is the insurance company saying that they value more?
Well, they're valuing more 97,530.
Right.
So
So, I mean, if the insurance company wants to see that because they value that code more, it just makes sense to me to show them that we're doing high level uh, therapeutic interventions, right? So
mhm,
if they feel like manual therapy is a low level intervention, I know we don't feel that way, but for sure, if there's room to say that this is an NR or a TA, then that's what they want to see, and that's what we're going to show them.
exactly. And with mobilization with movement, there are a number of things that you could easily put into 97,530 as well. Whether it's an upper extremity, whether it's shoulder mobilization with movement of reaching overhead, there's lots of active things that those patients are doing in a number of the techniques that Mulligan has shared with us. So it could be 97-112, or it could be 97-530. Um, and then just tactile cueing, just sort of falling into what we kind of generally look at as neuromuscular re-ed. But if you've got a patient who's doing scaption, if you are simply guiding that shoulder blade a little bit and cueing them some, now that automatically gives you the opportunity to build that as 97-112 if you choose to do that. And we'll talk about why there are advantages of choosing one code over another, sort of when we get to the end of this. Uh, Now, we roll down to 97-110, single leg stance. There we are. Uh, Instrument aided soft tissue mobilization. Think about what you do when you do that technique. And does it hit any of the things in the definition of develop strength, endurance, range of motion, and flexibility?
I just go to range of motion. I mean, that's the whole goal of doing it, right? Would be to improve some kind of range of motion, right?
Range of motion, you're doing things to the soft tissue. You get some tissue flexibility. You're getting layers of tissue to slide more, breaking up adhesions, all kinds of things like that. So A-stem, and in fact, we've talked to a number of uh, A-stem providers, disciplines, and they've said it's absolutely appropriate. They've talked to Medicare, they've talked to different payers, and there was no issue whatsoever in billing that as 97-110. So myofascial release, uh, an older cousin to ASTEM, I would say, the same thing. Where you're looking at range of motion and flexibility. If the intent of doing myofascial release is to get somebody to have more range of motion, more flexibility and mobility, then there you go. It doesn't have to be 97-140. Joint mobs. So you're doing a lumbar PA. Traditionally, that fits, and lots of people like to put that in 97-140. Are you not also passively moving that joint to improve some range of motion and flexibility?
Yeah.
Yeah. Are you, when you're doing a PA mode like that, are you not also maybe modulating some pain responses?
Affecting the nervous system for sure. I mean, I can send you stacks of
I mean,
research on the effect of grade 5
you know,
mobilization.
so,
So we're affecting the nervous system, right?
mhm.
Yep.
And then just simple passive range of motion techniques. Uh, you know, those are kind of the classics that fit in 97-110. And then lastly, we're going to come to the caboose, poor redheaded stepchild, 97-140 manual therapy. Uh, quite frankly, there aren't a lot of things that we do that we code 97-140 with any of our payers. But if you're looking at the definitions, mobilizations and manipulations, well, we already talked about the mobilization thing. It's a passive range of motion technique. It's a pain modulation. It's a nervous system modulator. So that can fit in something other than 97-140. I'll even sort of go out on a limb and say if you're doing manual traction on someone, are you tractioning their spine? Or are you stretching a variety of different intervertebral cervical muscles?
Yeah.
You're doing both.
Yeah.
So the advantage of having that ability to code something, to code an intervention differently is that particularly with the AMA substantial portion rule or the my favorite name, the 50% rule. It should be, I guess it should be the 51% rule,
The
right?
1% rule. Yeah.
1% rule is that you only have to do 8 minutes of a particular coded intervention to be able to capture that code. So you can look at the things you're doing and you can start to group them in a manner that you can capture more units than a straight 50. I got to do 15 minutes for that code. Not so much for the 8-minute rule for Medicare because that's really just a total time thing. But for the AMA rule, this is what gives you the opportunity to assign a different code. Uh, Now, one of the things you have to be careful with that is you can't code lumbar PA 97-110 on Monday, and then when you do it, code at 97-112 on Wednesday.
Unless you've changed something significant. So
Change
change.
something significant. Or if you can really document that, Monday, boy, they're really stiff. We need to work on that. Maybe on another day, they've got an acute flare up of pain and you're doing it specifically to, get a modulation of their nervous system. You have to be pretty specific. If you're gonna kind of walk that line, you just need to make sure that you identify the intent and what it is you're doing uh, in order to sort of justify why you're assigning that code that day.
So Chuck, is there any manual therapy technique, standard manual therapy technique that if you saw it not coded as manual therapy that you would have an issue? Can you come up with one where it's like, yeah, that's gotta be 97140?
Um,
So the fact that Chuck has to think really hard on this, it should give you an indication that it's kind of a struggle, right? So how about like a 97110? So this is definitely a therapeutic exercise. There's no way this is a therapeutic activity neuromuscular education. So let's say so a lot of the wording that I've seen is like one joint movements. So let's just say we had a quad set. So it's a very simple exercise. Man, if you're here on your fourth or fifth visit and I see quad set in your treatment plan, I need to ask some bigger questions than how you're coding it. But like if someone puts quad set in there, can you justify that as being a higher level TA or NR?
So for a quad set, if you want a 97 112, if you guys use Surface EMG units, that would definitely do it. That gives them some feedback. Again, if you are simply sort of physically cueing them, doing some facilitation techniques, that automatically makes it 97 112. The way you make that 97 530, Travis, is if you stand them up and you put them against the wall and you put a rolled up towel, a foam ball or something behind that knee, and now you have them doing a quad set in standing.
Yeah, which is a higher level exercise anyway. I mean, that's
Absolutely.
what you should be doing. Like if you should not be having people just on tables all the time anyway. So all of this, what Chuck is coding about is there's two advantages or goals. One goal is we've got to be doing higher level stuff. So if you're doing super low level stuff, I would say that you're doing the patient a disservice. And guess what? The insurance company is telling you the same thing, right, Chuck? I mean, they're saying we don't want to see a ton of, just straightforward manual therapy. Again, we've talked about how you can justify in terms of range of motion, how manual therapy can be justified as something else besides 97140. And therapeutic exercise, they don't want you doing that. For us, like a unsupervised, unskilled activity for us would be a warm up on a bike. Like if you're doing that, that's going to be for us a therapeutic exercise. But anything else that you know is really what you should be doing with the patient, man, I just can't see based on the definitions that you went over. It's written really gray, and let's talk about that a little bit. Why do you think it's written like that? Why don't you think Medicare has 75 exercises that are 97140 or well, that like neuromuscular education and therapeutic activity? Why do you think they haven't written it more clearly?
It would be more things that people would argue about that would get appealed in some cases or denied in some cases and not in others, and that creates chaos in Medicare. Plus, they're not the medical provider. They're gonna give us some general guidelines. Now, you're the professional. Do what you're supposed to do to get that patient to be able to function and back to where they need to be.
Yeah. Okay. Well, if you guys have any questions about this, if you're watching this, then you can reach out to Chuck Rye. But let's go over your summary slide here, Chuck.
Just briefly, so it's really important to know your fee schedule and that perceived value because of all the practices we work with over the United States. Um, there are some payers that have flipped those just a little bit. There are some payers that don't pay 97 530. Travis, you know anything about that?
Yes, I do. One of our pairs that we share says that for us, like 530 is an OT code, which I find interesting. I guess physical therapists don't do anything functional.
Yeah.
Yeah, but guess what? No matter how many times Chuck and I have called them and argued our point, they just don't listen to us. So we've got to play within their guidelines, right?
97,000 series is a physical medicine and rehab series. It's not a PT series and OT series. But anyway, yeah. And then you need to identify the need for the general types of information or interventions, I'm sorry, in the goals in your POC. That's just kind of a standard, right? We learned that in PT school, but just as a reminder, you need to make sure your functional goals are matching some of those functional things that you're coding for.
Yeah, understand how important those goals are. Like we could do a whole other thing on goal setting, but if you have a goal in here of get rid of pain, that's a terrible goal. Like I can't, I could try to justify the stuff that I'm doing in therapy to achieve that goal. But if I write a really good goal, I can justify that everything that I'm doing is geared towards getting the patient to achieve that goal. So yes, if it's a quad set that seems like a really simple exercise, I can justify, well, I'm doing this with the intent of their goal of being able to sustain single limb stance, or their goal of being able to walk 1 mile without feeling like they're going to fall because I'm strengthening their quad. And that is leading, the intent of that is to help them out with that very functional goal. So goal writing is very important.
Yeah, so now I'm kind of starting to sound like a broken record, but it's the intent is how you assign that goal, or rather that intervention, and be sure that you document it and describe it so that those two are consistent. So that makes it much more defendable. And then make use of the coding rules that you have. So AMA substantial portion rule is really important to look at and to utilize, and understanding how you can identify interventions with different codes makes that even more to your advantage.
All right. Hopefully that answers any questions that any of you or your staff have when it comes to how do we justify or designate exercises to which CPT code. I think we've done a pretty good job. I'm a little partial, but I mean, Chuck did a really good job. How about that? All right. Thanks, Chuck. And we'll talk to you guys soon.
All right.